Welcome to the ongoing home healthcare eligibility versus availability webinar. We are so thrilled that you could join us for what I think is going to be a very powerful session with our dear friends from RubyWell, whom I'll be introducing here momentarily. A little bit of an overview about what we're going to be digging into today. We know that the financial burdens and hardships that come with caregiving are plentiful, many. These hardships intensify caregiver stress by making access to services needed for our loved ones' care much more difficult. One example of this is the ongoing medically necessary home-based healthcare services that are often needed to keep our loved ones at home in a home setting. And so what many caregivers don't know is that some of these services might be covered by Medicare. So we're going to be diving into eligibility for this very underutilized benefit and do a walkthrough of RubyWell's online screening tool. By the end of this session, we want you to be able to piece together the eligibility criteria to know if your loved one may qualify for this benefit, to understand the steps to actually utilize the benefit, and to become acquainted and familiar with RubyWell's online screening tool. So that's just a little bit of an overview of what we have in store. My name is Nicole Goebel, and I am the Director of Community Initiatives here at Caregiver Action Network. If this is, I guess, your first rodeo, I guess as you could say, with Caregiver Action Network, we are a national nonprofit that serves the over 100 million family caregivers in the U.S. by providing supports and resources like webinars like this, as well as the number of resources that you can find online. And of course, we'll be hitting on a couple of different resources throughout the presentation today. So I want to turn things over now to Julie Kennedy and Suzanne Bautier from RubyWell. As a heads up, as we get started, we do have folks on mute, and this is a cut back on any echoing during the session, but please, please, please feel free to utilize those chat functions, that Q&A function, because we will have some time for Q&A at the end, and we'll be coming back to those questions. We'll be keeping an eye on those, so feel free to type in questions as we go. So without further ado, I'm going to hand it off to Suzanne and Julie.
Great. Hi, everyone. It's so great to be on with you today. And we know from working with so many caregivers at RubyWell that this is an urgent topic. So I thought I would start with a little bit of data, which won't surprise probably a lot of people on the phone or on the line, on the webinar, just to sort of frame family caregiving in the United States. So while CAN is working with over 100 million caregivers, RubyWell is focused on caregivers who are providing, usually more 18 to 20 hours or more of care a week. And we're generally focused on a population that's caring for an older adult on Medicare, though of course there are a lot of people who are disabled, who are younger than 65, who also use Medicare and who may need a caregiver. Incredibly, AARP tells us that the annual value of the work that all of you guys are doing is $600 billion, which, by the way, we think is dramatically understated, but at least really starts to reflect the enormous contribution to the US economy that our family caregivers make. And we also know that when you're providing this much care to someone, a lot of people have to leave their jobs to provide care, and that creates economic hardship for families. So RubyWell works with both families and with providers, with home health agencies. And we're specifically focused on this benefit that Nicole mentioned, and it is the Medicare Home Health benefit. So people on Medicare see home health in sort of two buckets. One is when you're discharged from the hospital, you're eligible for home health, which is mostly skilled care. So it might be nursing visits, it could be physical therapy, it could be other kinds of therapies that are provided to you in the home for up to 90 days or 100 visits. And then after that, you're expected to discharge. In many cases, you're expected to discharge before that, and they want you to discharge you before that. But there's another population who may actually be a subset of this post-acute population that needs ongoing care. This is a population that has chronic and complex disease, or may be coming out of a hospitalization, and even though they've received home health for 90 days, they're just not ready to be discharged. And by discharging them from this care, we're actually exacerbating the likelihood of rehospitalization, the risk of rehospitalization. And there's a population within this population here. Again, it's about 16% of the Medicare population, which is 11 to 12 million people in the US, who actually qualify to receive in-home health care on an ongoing basis for a very long period of time because they meet the medical criteria. And this is a population that is highly underutilized. This group of people generally don't know, Nicole, to your point, that Medicare will cover up to 35 hours of home health care to help you maintain your disease, help reduce the risk of deterioration, and help you stay at home. So we know from talking to families that older adults want to be cared for at home. My parents watched their parents age into homes and other types of care as they aged, and it is not what my parents want. They want to stay home. And we also know that a lot of people, in order to stay at home, particularly those who fit this complex chronic framework, really have family members who are having trouble making ends meet because they've left their jobs to do this work. And we have this huge population that is in place already doing this work every single day that we could tap into actually as a formal workforce to provide this care to their loved ones in a supervised, structured way. At the same time, the home health agencies, the healthcare systems, the providers who provide this care really struggle with workforce shortages and low retention rates. For home health aides, the turnover rate is about 100% on an annual basis. And a lot of people don't want a stranger coming into their house a couple days a week to provide care, particularly because that turnover rate means that you're getting a different person every time coming in. And so there's resistance, both there's high turnover rates because it's a difficult job. The home health agencies have trouble holding on to this workforce, but also the patient base isn't crazy about it either. And then for the providers, the home health agencies, reporting to Medicare is really difficult. And so because reporting is so difficult, it can mean that claims are denied. And what that creates are these reimbursement and margin contraction, which all that does is create this ongoing cycle of care not being offered that actually could be available. And as I talked about, despite these constraints, there are at least 11 million people eligible for these services. So let's talk about what this population looks like. This population is generally homebound. And so we want to talk a little bit about what homebound means. It means it's not that you don't leave home, it's that the Medicare beneficiary is not able to leave home without a mechanical device, which could be a walker or a wheelchair or some other device. Maybe it's a bus that has to come and get you. They need the support of another person, or their physician has told them that it's not in their best interest from a health perspective to leave home on a regular basis. And generally, this population has a caregiver. It's very difficult to be homebound and not actually have a caregiver. And so right now, you've got the family population essentially providing the backbone of that care in this country. So if this is the case, and we know who the population is that's eligible, why is this eligible, and why is this benefit not more broadly distributed? And one of the things that we don't have here, but I want to also raise, and which is part of the reason we're doing this workshop, is because one of the key reasons is lack of awareness. This Medicare home health benefit has been part of Medicare since 1965. It should be made available to people who qualify, but the Medicare population, the physician population, even the home health population doesn't actually necessarily understand what ongoing maintenance care looks like. So another big reason that you see that this care has not been provided is because there's something called the improvement standard. And you really see that post-hospitalization where there's an expectation that you're going to get better as a result of the care you're receiving at home and you're going to be discharged. And actually providers are incentivized through their payment schemes to follow that improvement standard and discharge a population. And if the population is not discharged, it can mean that the reimbursement rate that they receive is not as high. So there's an economic incentive that has been baked into the system that is focused on improvement. Now, this improvement focus is actually not official. It's not part of the law. And what we've seen is that in 2013, Medicare actually lost a lawsuit that said that, in fact, even if you weren't improving, we had to be able to provide care to maintain an individual's condition or to slow decline. So right now, especially even last year, there was a lot of circulars coming out of CMS telling traditional Medicare, the MACs, which is who process the bills for traditional Medicare and Medicare Advantage plans, they needed to be to stop denying home health coverage and to provide home health coverage. We talked about also just the compliance and documentation requirements. Medicare reporting is really complicated. And if you don't get the documentation done correctly, if you don't get the coding done right, then, they can deny the claim. And so I think in the absence of technology needing to do this manually, the questions for the providers really are, is it worth it to us? It's too much work. And then finally, as we talked about, the workforce really is just not there to provide Medicare covered home health. And yet we know that there's a ton of data that's come out of CMS even, that when you have a trained and paid family caregiver in the home, that there is up to 40% lower utilization rate. So this means less emergency room visits, fewer hospitalizations, family members feeling more confident in supporting their loved one at home, even when they feel that there may be a crisis that they have difficulty managing. Because in the context of home health, there are skilled services available to the household to help manage that care. So let's talk a little bit about specifically what Medicare actually will cover. So we talked a little bit about this improvement standard and how you in fact can access this benefit to maintain your status so that you don't decline or to slow decline. And again, this is something that can happen over a long period of time. It needs to be reauthorized by a physician every 60 days to determine whether the criteria are still met. And we talked about the fact that you need to be homebound. If you improve and are no longer homebound, then you won't be eligible for the benefit anymore. Homebound is really the core criteria. But there are other risk factors, and that is the ability to perform ADLs yourself. It is your risk of hospitalization. It is the primary and secondary and tertiary diagnosis that you may have that makes caring for you difficult. And so what this benefit covers is not just a skilled service, so a nurse who may come into the home, or a physical therapist or a speech therapist or occupational therapist who may come into the home once a week, once a month. If you have skilled services, there's also an allowance for things that are called dependent care. And dependent care are home health aid services to support the skilled services. And so these dependent services, the home health aid, are allowed to do all kinds of different things. Obviously, the ADLs are important: bathing, dressing, grooming, feeding, toileting, the things that need to happen to help the Medicare beneficiary live, thrive, and stay in their home. There are other things that they can do. The list is actually quite long, and we're not going to go through all of them right now, but under the supervision, which could be through Zoom, a home health aide can actually do some skilled services, which a lot of you are probably already doing: giving medication on a daily basis, making sure that prescriptions are renewed, cleaning a port or changing a port, or maintaining and supporting a patient who's on a catheter, or someone who has kidney disease and who needs to receive regular care at home. These are all services that are a combination of both skilled and unskilled that may qualify for Medicare reimbursement. And I want to define reimbursement. Reimbursement doesn't necessarily mean that you will get paid money back. What it means is that a service provider can provide these services for you in your home, and that Medicare will pay that provider. So we talked a little bit about the combination of the skilled services and the dependent services, and I want to clarify dependent services mean a home health aide as part of this integrated care plan. And the care plan every 60 days is really proving that by receiving these services, this Medicare beneficiary is, not going into the hospital, not going into a facility, is able to stay safely at home. And again, I think we talked about the fact that this is something that can happen on an ongoing basis. It needs to be revisited every 60 days, but assuming that you continue to qualify for benefits, you can continue to receive benefits for years. So I've already talked a little bit at a high level about ongoing home health. I'm not going to go too deeply because I've covered what homebound status means. We're going to circulate this presentation to you afterwards so that you can review it on your own terms, so that you can understand what homebound status means. But the core criteria to receive care at home really is based around this homebound status. So if you're able to get up and drive yourself somewhere on your own, then you're not going to qualify for this benefit. There may be other benefits you qualify. It could be you may qualify for some remote patient monitoring, or you may qualify for outpatient services. We're talking specifically about care at home. And we're going to get to the point here also of how your family member can participate in delivering this care. So homebound is really the fundamental core baseline criteria in order to qualify for this benefit. Now, there are other criteria that really matter, and hospitalization risk is a really important one. Has the Medicare beneficiary fallen recently? Have they been hospitalized recently? Is there a decline in mental, emotional, or behavioral status? And then there's a standard set of diagnoses that include a lot of cardiac, a lot of memory care, renal disease, and other diseases that are complex to manage, but when managed at home, both reduce the cost of care, but also can really improve the outcomes for the Medicare beneficiary who gets to stay at home. We've talked a little bit about the functional limitations that we look for in this population if they need help with ADLs, and that's dressing, bathing, basically the activities of daily living that one does on their own. If you need help with these activities, that is also taken into account. And these are things that probably the family caregivers who are on this webinar right now are doing already. So what RubyWell is really focused on when we think about the care crisis is moving from an environment where the system is sort of at the center of care and everything is determined by the system, to placing the family member and the beneficiary, the consumer, at the center of care. And we want to harness this labor that family caregivers are already doing and put that family caregiver at the center of the care team that is caring for loved ones who may have the opportunity to stay at home and be cared for at home. So by working with family caregivers, we could reduce staffing shortages. Families generally are much happier when they're both the beneficiary and the families themselves, and they feel more satisfied and they have better outcomes when they can stay at home. And then we've obviously talked about reducing cost. Now, Medicare, as you probably know, does not actually have a way to reimburse caregivers the way that Medicaid does. So I'm sure that a lot of people are aware of the self-directed funds or voucher programs or fiscal intermediary programs that occur at the state level that may allow family caregivers, some family caregivers, to get reimbursed for the work that they're doing. Medicare does not have programs like this. The new Medicare program that does focus specifically on family members currently is the GUIDE program. And that is for family members who are caring for a loved one with dementia. But again, what GUIDE offers is some training provided by a physician and the opportunity or the potential for some respite care. We feel that that doesn't actually address the larger financial constraints that a lot of family caregivers are suffering from, nor is it a way to really augment the workforce. So what RubyWell is doing is actually working with family caregivers who are providing care to a loved one on currently traditional Medicare. We will be moving into Medicare Advantage. And we help you take coursework that will help you get certified as a Medicare certified home health aide. And what that does is provides you actually with a health worker certification that is professional certification that you can use not only to work with a provider to care for your loved one, but actually what we've found for a lot of our caregivers is also a pathway for future employment when your loved one no longer needs care, or perhaps to care for more than one person at a time. So what does that mean? You can work with RubyWell. We can help you figure out, and Suzanne's going to talk about this a little bit more, whether your loved one is eligible for this benefit. Then we can help you get certified as a home health aide. And then we will help connect you to a provider who will both onboard your loved one to deliver home health under the supervision of a skilled care plan, and then hire you to provide the home health aid component of that skilled care plan in your home. And so Suzanne's going to walk you through the different steps that you can take, both with RubyWell to understand how we help you understand whether your loved one is eligible, and how you could potentially become trained and certified to be a home health aide and to follow this professional trajectory in order to be able to care for your loved one and get paid for that care. And then we're also going to talk about ways that you can explore this benefit separate from RubyWell and see whether you can find services in your own state, since RubyWell does not operate nationwide right now. So what we're going to do next is move over to our website and walk you through the quiz that will help us help you assess whether your loved one is eligible for the Medicare home health benefit. And I think there's a very important element here, which it says on the screen, and that is that this benefit is not dependent on your income or assets. The core criteria are related to your loved one's medical condition. So Suzanne, I'm going to hand this over to you.
All right, great. And I imagine that Julie just clicked take the quiz on the screen that she just had before you. And that would bring you to this. Oops, I've got to hide my, sorry. Got to hide my screen here. That would take you to our website where you would tap on the Take the Quiz button right here. So I'm going to do that. And basically what this is going to do is walk you through a brief questionnaire. Right now, it only takes about 5 minutes to fill out this questionnaire. And it does, it will give us a pretty good idea of if your loved one will be eligible for this benefit. So we're going to start the questionnaire. And it first asks us what state we live in. So I'm going to say that I'm in Pennsylvania because right now Pennsylvania is the state where we're running our pilot. And therefore, if I'm in Pennsylvania, I'm eligible so far. And I'm going to put a Pennsylvania zip code in here. And it asks me if I'm giving care or if I'm receiving care. So I'm going to be the caregiver in this scenario. So I'm going to click that I'm giving care. And I'm caring for, let's say I'm caring for my spouse. And it's going to ask us for the name of that spouse, just so they can make this a little friendlier. So I'm going to call him John. And John lives with me, so he's got the same zip code. So the first big question they're going to ask here is, which insurance does John have? And as Julie mentioned earlier, right now we're only working with the original Medicare. We hope to expand to Medicare Advantage plans soon. But for the sake of this walkthrough, I'm going to keep us on original Medicare so that we can continue. And then it has you double check, because sometimes people aren't really sure if they're on original Medicare or a Medicare Advantage plan. And the best way to check is to look at the card, the Medicare card, the healthcare card that you have. If it's this red, white, and blue card that says Medicare Health Insurance, that's original Medicare. If it's a card with other colors on it that has the name of an insurance company, that's a Medicare Advantage plan. So you want to confirm when you look at these, oh yeah, I definitely have the red, white, and blue card, or my husband John does. They have original Medicare. And then it asks which parts of the Medicare plan that they have. So the basic parts are part A and B, that's hospital coverage and doctor visit coverage. There's part D, which is drugs, and some people have supplemental plans to sort of fill in the holes for that part A and B, part B don't cover. So I'm going to say that we have a part D as well. And then it asks if John has appointed a medical power of attorney. And I'm going to say, yes, he actually did. And I'm the medical power of attorney. If he hadn't, I would have clicked no. And then it's going to ask us a few questions about the caregiving duties that I have for John. So which of these statements describe his ability to leave home? So here we're getting into the homebound status, right? So he, let's say he needs a walker to leave home. And, you know, he doesn't really leave home often because it's such an ordeal. So we just do it for short periods of time, maybe just to go to the doctor's appointment or maybe get his hair cut. So I'm going to click this one. Oh, I guess I only had to click one there. I'm going to click that one. And then it asks if John needs any of the following to leave the house. And as I mentioned, he needs a walker. And you know what? He also needs a ramp to use that walker. And you know what? He also needs me to help him down the ramp. So I'm going to click all of those. How many hours a week do I care for John? Oh, seems like the whole time, but I'm going to say 15 to 30 hours a week. And does he have a medical condition that makes it unsafe to leave home? And you can see the list of medical conditions that give examples of this. And I'm going to say that, let's say John has a severe cardiac condition. I'm going to click yes there. And then here we're going to get into some questions about what he needs help with. So this gets into his functional abilities. So he doesn't have any wounds or tube feedings, but I help with his exercises. I monitor his vital signs. I help him with daily tasks, activities of daily living. And that's really all that I have to do for John. And the last 6 months, what has John had? He's had an injury because he fell Nothing, like he's got some chronic pain. That he had that fall, so he has mobility issues. And that's really all that John is dealing with right now. And then I've reached the last section. It's saying that according to national average, home health aides can receive up to $1,800 a month for providing care. That's assuming you can get approved for 35 hours of care, or your loved one can get approved for 35 hours of care. Often it's a bit less than that. It might be closer to 25 hours of care or 20 hours of care. But we found that a lot of the family caregivers who are working for us, they'll take anything. Anything will help. And then it asks a little bit about me and my ability to work in the United States. So I'm a US citizen, so I can click yes. I'm living in Pennsylvania, and I'm a little bit older than 18, so I'm old enough. And are you willing to take a drug test? Yes, bring it on. And they ask that question because often to be hired by a home health agency, they'll want to have you take a drug test as well. And do you have a smartphone or tablet and access to a Wi-Fi where John lives? Yes, we do. That's important. And then do I have a home health aid certificate to provide home care? I don't have that, but that's okay, because as we know, RubyWell can help me out with that. So I'm going to say, no, I don't have that yet. And then I've got to provide my contact information. Suzanne. Yeah, my name. I've got to put in my phone number and my email address. I'm going to do sample. And then the best way for a team member to reach out to me, because someone's going to give me a call and help me walk through the next steps. So I'm going to ask them to text me first, and then we can make a plan for a call in that text. And I'm kind of a morning person, so I'm going to tell them when to text me. And if I don't qualify for RubyWell, I might be eligible for another payment program with one of our partners. Well, I'd be interested in learning about that if I don't qualify for RubyWell. So I'll click yes. And then you can sign up for our newsletter, which has a little quick hit once a month of some information that helps with the financial journey through caregiving. And then I hit submit. And this tells me that based on my answers, John and I may qualify for RubyWell. And the next step is to schedule a call with a member of the team. We'll click here and we will schedule a time that works for us for a member of the RubyWell team to get in touch with us. And they're going to call and confirm the information we provided them, dive a little bit deeper into John's health condition so that we can make sure that that he definitely, or he's more likely to be eligible. And then we'll go on to the next steps of the RubyWell process. So as you can see, it's a really quick questionnaire to find out if you're likely eligible. And then what I can do now is have Julie bring our deck back up and talk you through what happens next. Julie, let's start on the RubyWell journey slide first, since we're in the RubyWell headspace.
Great. Yeah, and I know we have a lot of questions in the chat that I'm trying to respond to.
Oh, great.
And oops, this took me back to the beginning. And I think, yeah, going through this journey, I think is great. And then also just helping people understand, even though we only operate in some states, how they could maybe take advantage of the benefit.
Absolutely, absolutely. So, so what I just talked about in showing you the screener is this step number 2, verifying patient eligibility. So you do the first questionnaire, and then you have a call with one of our a member of our team, and they're going to dive a little bit deeper. They're going to ask you to provide Medicare claims data and tell you how to access that. And this will all be proof points that we're going to gather into a great discussion guide that you can then take to your loved one's doctor. And you can do that in person, or you can do it via telehealth, and have a discussion with them about whether or not the doctor thinks that your loved one is a good candidate for home health services. And this discussions guide is going to have every single proof point that you shared with us and that Medicare claims data shared with us, so that they can have a really clear picture of how home health could help your loved one. And then if they agree, they will write a prescription for home health that you'll share with RubyWell. And at that time is when we get you engaged in your family caregiver or home health aide training program, which is, it varies by state how many hours this is. Most states, it's about 59 hours of online coursework and then 16 hours of in-person hands-on training. That's usually done at the home health agency where you would end up being hired to care for your loved one once you're certified. So we help you get through that training process and certification process. Then we match you with a local home health agency who takes on your loved one as one of their patients, hires you as a home health aide, and then you can provide their care as outlined in the plan of care that is developed for you based on your loved one's health condition. And then you just keep doing what you're doing. You're going to have the support of a skilled nurse as well, which is really wonderful. And people are going to be, it's nice to have someone to call when you're not exactly sure what to do. And then we work with the home health agencies on the whole back end, the billing process and what have you. So, and you get paid by the home health agency for the hours that you are approved to work. So that's how the journey works with RubyWell. If you don't live in Pennsylvania right now, let's go to how you might be able to access this benefit directly from a home health agency. And let's see.
Patient issues here.
So if you're feeling like, well, my loved one is definitely homebound and they have they've been to the hospital a lot lately or a couple times this year, they've had a fall, they need a lot of help with their daily activities. If you're feeling just from what we shared with you today that your loved one may be eligible for this, what you can do is make an appointment with their doctor and go to them with all of your observations and the more information you have in terms of dates and times that things happened, either hospital visits or surgeries or falls or injuries, and have this conversation about how you think that home health might be beneficial and would the doctor also agree based on these health conditions. And if your doctor agrees, ask them to write a prescription for home health. And then what you've got to do is start calling home health agencies in your area to see if they accept Medicare patients with a home health prescription. And this can be where it gets difficult because, as Julie mentioned earlier, a lot of home health agencies either aren't aware of the ongoing home health benefit through Medicare or don't really feel capable of dealing with the Medicare process to provide that home health. But if you find one that takes on Medicare patients, you'll provide that prescription to them and schedule a visit with them, an intake visit with them to initiate the care plan. So they'll come to the house, they'll meet with you and your loved one, and they will determine based on the doctor's prescription and what they learned from you at the house, what kind of home health care would be beneficial for your loved one. They'll then give you the care plan, and then all you at that point have to do is wait for a home health aide to become available to then provide that care to your loved one. They might have one ready right away. It might take a while for one to free up. And then, as Julie mentioned, you might not always get the same one. If you need quite a few hours of care, you're approved for quite a few hours of care, the same one might not be there for all those hours. So there might be a bit of a revolving door of home health aides coming in their house that way. But once you have one, then they begin the home health visits and Medicare will reimburse them. So that's how you would access home health if you're not in a RubyWell state right now. So I think that wraps this up. And I do see lots of questions in the in the Q&A section.
Yes, we've had lots of great questions. I know we've covered a little bit of them just in going through, I think, a little bit of those logistical pieces. And Julie, I know you've been answering some in the chat as well, so thank you. Obviously, the big question has been if you're only providing this service in Pennsylvania directly right now, what do we do if we're not in that state? And we just walk through that. As I mentioned at the top, if you are interested in getting a copy of this slide deck, please reach out to info@caregiveraction.org. We were going to make it available on the website, but there's some accessibility issues that can come with that. So please feel free to reach out to us directly by email. And we're more than happy to assist you there. And of course, there will be a recording of this available on the website as well. So a couple of the questions, I know that Suzanne, you were kind of monitoring them. Were there any that you wanted to kind of kick off with?
Yeah, I'm looking at Josh Jenny's question. It sounds like I understand your question, but I think you got the words Medicare and Medicaid switched. So if your parents' two Social Security incomes are if they are too high, that means they wouldn't qualify for Medicaid. So those are the mostly state-run programs that have waivers and voucher systems that do pay family caregivers. So if your parents' income is too high to qualify for Medicaid, then they are likely on Medicare. And RubyWell works with original Medicare beneficiaries. Your parents may be on original Medicare or they may be on a Medicare Advantage plan. And we talked about telling the difference based on what their insurance card looks like. If it's just a red, white, and blue card that says Medicare, that's original Medicare. If it's a more colorful card that has an insurance company's name, that's a Medicare Advantage plan. So Medicare, as we said, does cover ongoing home health. And we walked you through how to access that. It takes some effort and it takes some time, but if you can access that benefit through an agency that covers Medicare patients, it's worth it.
Yeah, go ahead. Sorry.
No, go ahead, Julie. I just wanted to bring up, and we're talking about eligibility. There was one question. I think you may have covered this, but I just wanted to make sure to maybe hit on this. There was a question that came through the Q&A. If a person can no longer drive, does that count as needing the assistance of another person to leave home?
Well, can they take a taxi by themselves to go somewhere? So then that would not, if it's just that your driver's license has been taken away or you're not allowed to drive anymore, maybe because you're blind. Blindness is an interesting question because in some cases that could potentially qualify. But generally, if you can walk out of your home and get on a bus or get into a taxi on your own, then you would not be considered homebound.
Okay, thank you for specifying that. I know there was some conversation in the chats that kind of hit on similar questions, so I thought I would bring that one up.
There's some other ones there are a couple things that I wanted to also address. I think the first one is that a lot of people are saying that they don't want someone to come into their homes. So we understand that. And part of what we're trying to do here, and again, while we understand that there's some frustration in the chat that we only operate in Pennsylvania, we will expand. And the point is, though, that by becoming certified as a home health aide, you would be providing the care yourself to your loved one under the supervision of a nurse at a Medicare certified home health agency. So while you may still have for skilled care somebody coming in, if you are certified as a home health aide, you would be able to provide a lot of the care for your loved one. And so that's the first one. I think the other one that keeps coming up is as it relates to Medicaid. This is not a Medicaid benefit. This is a Medicare benefit. And within Medicaid, there are limitations to who could get paid as a caregiver. And that is because the funds for Medicaid are paid directly through self-directed funds to the care recipient to distribute. Medicare doesn't move money in the same way. And so by becoming certified as a health worker, you are sort of being transformed from a family member into a professional. And in your professional status, you are being hired to provide this care to your loved one, which means that the constraints related to whether you're a spouse or a child or whatever the direct relationship is within the context of Medicaid do not apply in this situation. So I just wanted to address those two questions.
Fantastic. No, I'm glad that you did, because yes, this had come up quite a bit. There, in looking at the Q&A, there have been a couple of questions about, what I think it goes back to what you were discussing in terms of what qualifies as the kind of care covered here. Because there have been some questions about supplies that may be covered through this. And so I didn't know if you just wanted to kind of piece that out a little bit just for some clarity for folks.
Sure. So let's talk about the different kinds of illnesses that we see being approved for this care. So cardiac, any underlying primary, secondary diagnosis that is cardiac related tends to be something that is viewed as a very high risk for hospitalization and can create complexity in treatment of disease. So cardiac, congestive heart failure, respiratory, COPD, you see a lot of that qualify. A lot of the complications from type 2 diabetes would fit under this. And where you also see a lot of complexity is for people who may have dementia or memory care disease, have other complications that are related to either cardiac or related to other complexity within their disease. We see a lot of type 2 diabetes and memory care patients. And so in a lot of cases, those qualify as well. I know someone was just asking about a respite care voucher. And where I've seen respite care vouchers is under the GUIDE program. This could complement the GUIDE program. It doesn't necessarily need to be one or the other. And I was just trying to get clarity on whether in that context, if you're a member of the GUIDE, if your loved one is being treated in the context of the GUIDE program and receiving voucher coupons through GUIDE, you could also still, if your loved one meets the criteria beyond a simple, I'm not going to say a dementia diagnosis is ever simple, but a simple diagnosis of dementia without other complications. In that case, it may not qualify, but if you're caring for a loved one who has dementia and other complications, then that might also be an occasion where care would be approved. So I think there's a couple important points that I want to make here, though, even as it relates to just frustration about where Ruby-Well is operating. And that is that while we will help facilitate you and the home health agency to deliver this benefit, you could go out and become certified as a home health aide, and we could provide some information on resources for that we can provide to Nicole through CAN. We could also make the quiz available through CAN so that it's not rejecting based on Pennsylvania, so that everyone can just go through and see whether they could potentially qualify. So there are things like that we'd be happy to do with CAN to help people figure out if they qualify, because you could engage in a conversation with your physician to request this care for your loved one in any state. And that is both in the context of traditional Medicare and Medicare Advantage, I can provide a short write-up on the way you would want to frame the conversation with Medicare Advantage, because it is harder to access these benefits through Medicare Advantage than it is through fee-for-service Medicare, which is original Medicare. But we can give you some tips on language to use that you could use when you speak with your physician.
That would be absolutely wonderful, Julie. And if you wanted to make those available, I've shared and others have shared in the chat the info@caregiveraction.org email address. If you are looking for that information, please feel free to reach out so that we can send those your way. We may be able to find a spot to put those on the website as well. But if you want to get that direct access to them, once it gets handed over to CAN, we're happy to hand it over to you all. So I really, really appreciate that. And I think the feedback here has been really wonderful in terms of helping us figure out, like, what are those questions, concerns, issues, excuse me, that family caregivers are encountering when first learning about this benefit. Because, you know, as we started off talking about, this is something that a lot of caregivers don't even know exists. And so, you know, once you learn that it's something that's feasible, what are some of those hurdles that we can help?
Yeah, a couple of other things I'm seeing in the chat. One is that if you are, and I hate to talk about this, but especially in the environment that we're in right now, if you are in the United States legally and are legally able to work in the US, then these benefits apply to you. And I am not trying, I don't want to make a political statement. You just need to be able to be hired above board by an agency in order to be able to get paid for these benefits. So be able to be formally employed. But I'm born and raised in Canada. So but I am able to be in the United States legally. And so anybody who's born anywhere else, as long as you're able to work in the US legally, you could become a caregiver, a home health aide. So I just wanted to provide that clarity. The other thing is, I don't want to write this down in the chat. I cannot advise you, we're not allowed to advise you on your choice of Medicare plan, because there's lots of regulations around marketing Medicare plans. But you are allowed to change from traditional Medicare to Medicare Advantage and from Medicare Advantage back to traditional Medicare. You are able to make those changes. I believe you can move back to traditional Medicare from January 15th to March 15th every year. My husband is
I think March 31st.
March 31st. My husband's actually a Medicare broker. I should know this. I don't remember off the top of my head. And then definitely during open enrollment, which is October 7th to December 15th every year. So you are able to move between plans. Now, if when you aged into Medicare, you went on to a Medicare Advantage plan. If you now switch to original Medicare, and you want a supplemental plan, which is what covers the 20% that Medicare does not cover under original Medicare, you will need to be underwritten if you want a supplemental plan. And meanwhile, if you sign up for original Medicare and you buy a supplemental plan at that time, you do not need to be underwritten for your supplemental plan. So there's a little bit of a difference there, and there's obviously no underwriting with Medicare Advantage plans. And the other question that keeps coming up is, what's up with Medicare Advantage? So this is a benefit that is legally available under Medicare Advantage. So the way Medicare Advantage works is that they're required to provide everything that original Medicare provides. And then they, through their capitated rate and their agreement with the government, can also provide additional benefits. What you see a lot is dental care, eye care, hearing aids, things like that. And those can also be included by the plan. And then the way Medicare Advantage plans work is that they get paid a monthly rate by the government for these individual patients based on your risk profile and based on where you live and based on these other things. And so what Medicare Advantage plans try to do is help to make sure that the care you receive costs less than the care they're being reimbursed for on a monthly basis. And so what that generally means is that they are much more restrictive about home health because Medicare Advantage has not yet really understood, and we have a lot of data to show this, that keeping people in the home and paying for home health, in fact, will cost them in the long term much less than not offering that benefit. So they haven't made that mental switch yet. So we are working with a number of plans right now. We're building out actuarial models. We're doing all kinds of stuff that's not interesting to people on this call, but to try to make that explanation. But as I mentioned, Nicole, I'm going to just send you over some language that you can post on your site that can help your members here guide a conversation with a Medicare Advantage plan in the context of managed care for their loved one that they could use in requesting these services if their loved one meets criteria, is medically eligible. It can just be harder to access those benefits. And again, with Medicare Advantage, you would need to use a home health agency that is in network for your plan. Original Medicare tends to have a much broader choice of agencies that they can use. I'm not saying one is better than the other because there are different costs associated with each one. So.
Thank you so much. Well, I do want to be mindful of time. We are at 2 p.m. I think we could do a whole other 2 hours on this and really delve into the questions. So to kind of close things out, obviously, questions, concerns. How do you get connected with other resources, services in your area to help with some of those day-to-day caregiving bits and pieces? Got a slide up here that talks about the Caregiver Help Desk. The Caregiver Help Desk is a wonderful resource that, you can reach out via phone, chat on our website. So if you go to our website, you'll see a big orange help desk button on the bottom of the screen, and you can click that. And you're going to be connected to a caregiving expert, someone who is going to be a listening ear, but also be able to help you, point you in the direction of those supports and services that you need. Oftentimes, those services are organizations or providers that are in your backyard. So being connected to those directly. And so please, please, please feel free to reach out to the help desk. It's a wonderful resource and a great place when you don't know where to turn to your with your caregiver questions. So I want to flag that. I know in the chat we have put in the info at caregiveraction.org email address if you have additional follow-up questions, or if you want to request those slides, some of the follow-up information that we're going to be having in partnership with RubyWell and kind of coordination with this. Happy to send it out to you all. And of course, caregiveraction.org, lots of other resources there. So spend some time exploring what's on the site. We have been having some really well-attended webinars as of recently. I recognize some folks who are at a previous webinar, and I want to also just put it in your mind, maybe you've seen this, as we've just started sharing about it on social media. Our next webinar is coming right up, and that is going to be, I want to make sure I have my day right. That is going to be on the 27th of February, so next Thursday from 2 to 3 p.m. and it's Living with Incontinence, Empowering Care and Practical Solutions. So you'll see information coming out about how to register, just like you did with this webinar. So really want to keep that flagged for you as well, because I know that will be of interest to some of the folks here.